Hey everybody, the purpose of these little education offerings is to address the things, sometimes big, sometimes small things, that will help us advanced providers manage patients a little better. They'll have better outcomes, and be honest, just plain make us and our supervising docs and Dr. McGovern look good. Anytime Dr. McGovern isn't spending defending us, is more time he has to advocate for things, like us doing open thoracotomies on grade 3 ankle sprains, all the good stuff. With those goals in mind, when I asked Dr. McGovern what he wanted covered first, no hesitation, he said appendicitis. I think this is an easy one to improve on. A little heightened level of suspicion, less anchoring on classic presentations will reduce cases of missed appendicitis. A couple documentation points will help us justify our decisions, back us up a little bit better, specifically imaging and disposition decisions, and a couple reminders on management will go a long way. This is a brief review of things you probably already know, perhaps have forgotten, and maybe even a couple pearls you didn't know about. What this is not is a comprehensive review of appendicitis, because good grief, who wants to sit through that? Okay, so for a little pathophys review, this is from a YouTube channel called Osmosis, and it's obviously narrated by the same guy that did the honey badger video like 10 years ago. So props to him. Here we go.
The appendix is the little one-ended tube that's attached to the cecum of the large intestine. Sometimes it's called the vermiform appendix, where vermiform means worm-shaped, so that should paint a pretty clear picture of what it looks like. And this odd, kind of cute little worm-like structure's function is actually unknown, though some theories suggest that it might be a safe house for gut flora, and some evidence seems to suggest that it plays a part in the lymphatic and immune system. Other, arguably more cynical viewpoints think that it's just a useless vestigial organ from our ancestors. Whatever the case may be, the fact remains that it's pretty talented at getting inflamed and causing abdominal pain, a condition known as appendicitis. As much as 10% of the population develops appendicitis at some point, and it's the most common surgical emergency of the abdomen. Since the appendix is a hollow tube, the most common cause of inflammation is something getting stuck in or obstructing that tube, like a fecalith, which is a hardened lump of fecal matter that finds its way into the lumen of the appendix and wedges itself there. It could also be other things though, like seeds that weren't digested, or even pinworm infections, which are intestinal parasites. Another cause of the obstruction, especially in children and adolescents, is lymphoid follicle growth, also known as lymphoid hyperplasia. Lymphoid follicles are dense collections of lymphocytes that get to their maximum size in the appendix during adolescence. Sometimes this growth, though, can literally obstruct the tube. Also, when exposed to viral infections like adenovirus, measles, or even immunizations, the immune system ramps up and these follicles can grow as well. Whatever the cause of the obstruction is, now the appendix is plugged up, right? Well, the intestinal lumen, including the appendix, is always secreting mucus and fluids from its mucosa to keep pathogens from entering the bloodstream and also keep the tissue moist. Even when it's plugged, the appendix just keeps secreting as usual. When this happens, fluid and mucus builds up, which increases the pressure in the appendix. And just like when you fill up a water balloon, it gets bigger and physically pushes on the afferent visceral nerve fibers nearby, causing abdominal pain. Along with that, the flora and bacteria in the gut are now trapped, right? And intestinal bacteria that are usually kept in check in the gut, like E. coli and Bacteroides fragilis, are now free to multiply. And this causes the immune system to call up white blood cells, and pus starts to accumulate in the appendix. This activation of the immune system can be seen in the lab as an increase in the serum white blood cell count. Patients might also develop a fever in response to the infection, which in combination with right lower quadrant abdominal pain, at the point roughly where the appendix is, known as the McBurney's point, is a super important sign for identifying appendicitis. Also, along with the fever, other classic symptoms include nausea and vomiting. Now, if that obstruction persists, the pressure in the appendix increases even more. At a certain point, as the pressure keeps going and it continues to swell up, it pushes and compresses the small blood vessels that supply the appendix with blood and oxygen. Without oxygen, the cells in the walls of the appendix become ischemic and eventually die. Since these cells were responsible for secreting mucus and keeping bacteria out, now the growing colony of bacteria can invade the wall of the appendix. As more cells die, the appendiceal wall becomes weaker and weaker, and for a small proportion of patients, it gets weaker to the point where the appendix ruptures. Rupture of an infected appendix allows the bacteria to escape the appendix and get into the peritoneum, and patients often experience peritonitis with rebound tenderness, meaning pain when pressure is taken off, again around the McBurney's point. Patients might also have some abdominal guarding, where the abdominal muscles tense up when pressed to try and avoid pain. The most common complication with a ruptured appendix is pus and fluid getting out and forming an abscess around the appendix, called a paraappendiceal abscess. Sometimes subphrenic abscesses might also form, and these would be tiny abscesses below the diaphragm but above the liver or the spleen.
Now in that video, one thing I'd like to point out is he mentions right lower quadrant, pain, McBurney's point, and all that stuff. And these are the classic presentation that we all know. It's a vague periumbilical pain, migrates to the right lower quadrant over time, becomes more localized, more severe. And that's kind of what we all look for, right? Just a reminder of why this is. Abdominal organs, visceral peritoneum sensory innervation is essentially just sensitive to stretch, ischemia, inflammation. The signal pathway from the organ sensory receptors through the splanchnic nerve into the dorsal horn of the spinal column results in this vague midline sensation, regardless of where the organ is. So it's always in the midline. The only real localization is superior and inferior. So all the foregut structures, like the gallbladder, the pancreas, they enter at T5 through 9, and they result in that epigastric pain that we all know, for biliary colic, pancreatitis, stuff like that. And then in midgut structures, which include the appendix, they enter at T10 and 11. They result in that periumbilical pain. And it's kind of vague, midline periumbilical. And the hindgut enters at L1 and 2 and result in that suprapubic infraumbilical pain. And the parietal peritoneum is innervated directly. So once the inflammation extends beyond that organ and irritates the parietal peritoneum, that's when the pain migrates to the right lower quadrant, becomes more focal. You get that focal tenderness, guarding, pain with movement, and jolting, stuff like that. So that means we can just look for that pattern of pain, tenderness, and we are golden, right? Nope. First of all, we all know our patients don't read Tentinelli and they don't follow the rules. They get diabetes, they get old, they just don't perceive pain in standard fashion, or they show up pregnant with a displaced anatomy, or their appendix is in a variant location. Some examples of those variant locations are you could have a retrocecal appendix. And in that case, that inflammation never reaches the parietal peritoneum. So you get this poorly localized pain, no pain with cough and the walking, those kind of classic things. You may have urinary symptoms, hematuria, phlegmic pain. So much for that. Everything being simple and clean and classic, right? If you have your appendix is actually down the pelvis, then you get the nausea, the vomiting, the diarrhea, and the pretty benign abdominal exam. So it sounds a lot like gastroenteritis, doesn't it? And I know that I've sent people home with gastroenteritis and signs and symptoms, which, looking at this, appendicitis can cause the same symptoms. And then if you have a high position cecum, then appendicitis can actually present as right upper quadrant pain, so mimics biliary colic. So an atypical presentation is not an invitation to turn off your suspicion completely just yet. And as we see here, some of the atypical presentations are actually classic for specific anatomic variations. About differential diagnosis, I'm not going to bore you with a long list of common differentials that we all know and look for every day. What I will say in general about differentials is don't forget those surgical emergent ones like bowel obstruction, ectopic pregnancies, testicular torsion. And be sure to factor in patient history, as this can lead you to some specific differential diagnosis too. A good example is that cirrhotic patient who ends up coming in every few months for paracentesis, or the one who does peritoneal dialysis at home. They are both at a substantial risk for spontaneous bacterial peritonitis. The few cases of SBP I've had, they did not present with this really impressive abdominal exam always. So you really have to have a high suspicion for it, because it doesn't always just jump right out at you. So here are a few differentials I think we sometimes overlook. And this is just an off the top of my head kind of list. I'm sure that you're all thinking of some right now that I've overlooked. Speaking of one of those differentials, pediatric DKA, really think about that one. With those kids who have had abdominal pain longer than a couple of days, and they're really localized, as you know, so it just doesn't sound like appendicitis. And you look at the kid, and they have this ongoing nausea and abdominal pain, and they just kind of look punky. There's a good chance that actually that's their first DKA, so just keep an eye out for that. Speaking of that DKA, so it's late, and you get the scenario here that you see on the screen, and you get labs on your 3-year-old with abdominal pain, and it's just as you kind of suspected, they're in DKA. The doc isn't immediately available. They're off in the back doing those thoracotomies on the grade 3 ankle sprains, and you are really feeling like a hero. You've managed to feed plenty of adults with DKA, and you just want to get stuff started. So, for a minute here, I'm going to look back to lessons learned way before I was a PA. And that is, first of all, just hold on there, Skippy. The Intergalactic Pediatric Center is right down the street, and this is a slam dunk transfer. So you don't have to do much other than don't mess this up. So your number one job is not to achieve euvolemia or to close the anion gap or to correct glucose or to resolve acidosis. It's none of that. Okay, your number one job is don't be that guy. Don't be the one responsible for a brain-injured kiddo due to cerebral edema. So here are some ground rules. No insulin boluses, and really no insulin in that first hour of IV fluids. Which probably means, safest thing, probably no insulin before they get transferred. Don't let their glucose fall more than 100 milligrams per deciliter per hour. So, this is a very gentle management of their glucose. No IV fluid boluses unless you're really saving an organ, that shocky patient with no urinary output or an altered mental status or something like that. And if you do have to do a bolus, just do like 10 mils per kilogram, instead of the usual 20 that we're all used to doing. Because number one goal, no cerebral edema. As far as IV fluid infusions, really between 1.5 maintenance and twice maintenance. Twice maintenance is that absolute max that you want to go, because your number one goal, again, is don't be that guy. As far as maintenance fluids for kiddos, it's pretty easy to figure out. Just remember 4-2-1 for the rate in milliliters per hour. So 4 milliliters per kilogram per hour for the first 10 kilograms of the patient weight, and then for the next 10 kilograms from 11 to 20 kilograms is going to be 2 milliliters per kilogram per hour, and then after 20 kilograms then it's just another additional 1 milliliter per kilogram per hour. So here's a little shortcut. If your kid weighs 20 kilograms, it's 60 milliliters. So if they weigh more than 20 kilograms, it's 60 plus 1 per kilogram over that per hour. So an example would be kid weighs 25 kilograms. It's going to be 65 milliliters per hour. And if you want to do twice maintenance, it's going to be 130 milliliters per hour. And that is about it. Don't go beyond that. Don't be that guy. On to labs. So one thing I'll say about the CBC, though, is that while a negative CBC is not very helpful, even a mild leukocytosis and a little left shift is going to sure make us look bad if we send them home and they bounce back with appendicitis. So at this point, if I have any leukocytosis in an abdominal pain patient, I need a really solid explanation for it before I send them home without imaging, or a very good shared decision making a conversation in MDM, with a patient, parent, supervising doc. The urinalysis, also useless in ruling out appendicitis. Don't get excited because you got a dirty urine and think that you just ditched appendicitis completely. The absolute neutrophil count. And that's not so that we can look at in isolation. It's actually is part of the pediatric appendicitis score, which is a pretty useful tool to support your medical decision making on imaging and disposition. The CRP also, it's not a great tool to rule out appendicitis. It's sometimes it's requested by the peds folks, so keep that in mind. You can order it just in case they want it. And where the CRP is actually more useful is in looking for perforation and abscesses. A little about decision tools. There are a couple useful, well-validated ones out there. I'll just talk about two here. One is the pediatric appendicitis score, and for adults, the Alvarado score. One of the useful things about these tools is that if your decision to not CT or ultrasound is consistent with the risk assessment of these tools, then you have something to document as decision support and to fall back on. Also, in theory, if the score were high enough, that would justify calling surgery without imaging due to a strong suspicion. And I'm sure that might be true in some in academic school podcast land somewhere. I'm not going to try that in our shop anytime soon. I'm just going to get the imaging. The pediatric appendicitis score here that you see in front of you, it's pretty straightforward. If the ANC doesn't show up in the CBC differential, you can always calculate it on your own. You can use MD Calc, or you can just multiply the white count by the percentage of bands. And you can see the score off to the right there. So the 0 to 2% risk supposedly supports not getting imaging. That's not a replacement for your gestalt though, right? Personally, if I have a kid with well-focalized right lower quadrant tenderness, I'm pretty much going to ultrasound them at least, even if they have a score of, let's say, 1. Not necessarily, but there's a good chance I am. Where it is more useful, I think, is that kid with abdominal pain and a fever, and you have a really good reason to think of something else. Maybe it's not well-focalized pain. And then this offers you some backup for that decision. The middle risk range pretty much means they need imaging. And then at the top of that range, in that 78 to 96% range, that score over 7, in theory, like I said, supports calling surgery without imaging. Like I said, I ain't going down that way. I'm pretty sure I know how that phone call would go if I tried that. Here is the Alvarado appendicitis score for the adults. The components of this are pretty straightforward as well. So per MD Calc, a score of less than 3 is about 96% sensitive. And it says studies show on that. So I don't really know how well validated this is, other than I don't think a decision-making tool would make it on MD Calc without some validation. And again, if you're going to get a CT or ultrasound, the decision support part of this is less important, right? Because you got the imaging. I'm going to try to include these scores in my MDM either way, just for consistency's sake. But where it's really more critical is when you're not getting that imaging. So now on to imaging. First of all, you don't have to get a CT or ultrasound on every abdominal pain, but I do think our threshold to do it could definitely be lower. I'd say it should be easier decision to get an imaging than to not get that imaging. Ultrasound, of course, is preferred for pregnant patients and kids. Even that is not an absolute. And deciding to CT a kid or pregnant patient may be unavoidable in some cases, and that's definitely one of those shared risk-benefit decisions that I would share with the doc and the patient and the parent. And I don't think I would go that one alone myself. Everywhere you read about ultrasound appendicitis, you see operator dependent as far as the accuracy and the reliability of the test. So far, my experience, that usually means everybody's going to say appendix not visualized unless it jumps out at them. And all the operators who are really consistent can always see the appendix. They seem to work somewhere else. Here's a good overview of the CT findings for appendicitis. It's from EM5 on YouTube. It's Dr. Anna Pickens, and she's got a ton of these little 5, 6, 7 minute videos, which are really good.
This week for EMN5, we're going to go through appendicitis, which is a part of this series on CT imaging for the ER physician. And the first thing you have to do for appendicitis is actually find the appendix, which actually can be fairly tricky. My key here is that you need to find the colon first. So let's go through a couple pictures. Here we have the ascending colon. Let's identify the descending colon over here on the left. And then we have the transverse colon. So now we've found the colon, and specifically we found the ascending colon and the cecum here, and we're going to basically be looking somewhere between the umbilicus and the pelvis, or the cecum. We should find the appendix. So that's where you're going to be scrolling through to try to find it. So in an appendicitis, now that we've found the appendix itself, we should be looking for these findings. So first, a dilated appendix, anything bigger than 6 millimeters. You should also see some appendiceal wall thickening, greater than 2 millimeters. You'll probably see some fat stranding around that area. The wall of the appendix should be enhanced, and maybe even the cecum will be a little bit enhanced or thickened. So let's look at some examples. In this patient, we've identified the appendix. We've measured it. It's 17 millimeters. What do you think? Is this patient sick or not sick? Good, so this patient is sick. The diameter is greater than 6 millimeters. In fact, it's 17. It's quite large. What about this one? So we've identified, here's our appendix right here. Good, so this is not sick. This is a normal appendix. We see there's air inside, no fluid. It's not dilated, and there's nice dark fat around it, so there's no fat stranding. This is a normal appendix. What about this one? This is a really good example of a sick one, right? So this is appendicitis. We are dilated. The rim itself is enhanced. So you can see it's brighter than the rest of the bowel if you were to look at the rest of the bowel. It's also fluid filled, so that's not a good sign. And then we have a lot of fat stranding around it. So here's some nice dark normal fat right around the appendix. If we see these enhanced strands, that's fat stranding. Fat stranding is key when you're looking at anything on a CAT scan in the abdomen. It'll basically lead you right towards your diagnosis. So if you're scanning through a CAT scan, look for fat stranding. It'll cue you right into what your problem is. So why do we do IV contrast in appendicitis, or really anything that we're looking at bowel? Well, that's because it actually lights up the bowel wall. Here we have the same exact picture except with IV contrast. And you can see that the bowel wall is very lit up. It's very bright. It's a lot easier to see. And you can also see if the wall itself is enhanced or thickened a lot better than on this other scan. Okay, here's another example, definitely appendicitis. So here's our appendix. It's dilated, it's fluid filled. The rim or the wall is enhanced and thickened. Okay, how about this last one? Sick or not sick? Definitely sick, right? This is an example of a perforated appendix. It's neat because in this scan you can actually see where the defects in the wall are, so that's the perforation. And then what is all this surrounding it? That's fluid, right? So you have a fluid collection here, a lot of fat stranding. So, in 3 to remember for appendicitis imaging on CT scans, we're looking for a diameter greater than 6 millimeters. We're looking for wall thickening and enhancement. That's why we're getting the IV contrast so that it'll light up really well. And we're also looking for fat stranding. Look for fat stranding anywhere on a CAT scan when you're concerned about some kind of pathology.
Okay, so history, physical exam are done. You want to send the kid home without any labs or imaging. And good chance that it's the appropriate next step. Just take a moment to check for that little voice in your head, the one admitting that this one is not a slam dunk and that you're sending them home with a gamble and a hope. And if that voice is there, even just a little bit, then take a minute to reassess your rationale and all the facts behind it. How well your chart's going to be able to defend you, because that little voice may be trying to save you. One thing I always try to get into the chart on these kids is the conversation they need to have a repeat abdominal exam within 12 to 24 hours at the longest, and that they need to return to the ED immediately for any increased symptom or new symptoms concerning for appendicitis. And also what I do sometimes is I'll tell mom or dad that if that pain completely resolves and if they're looking great and everything's wonderful, then they probably don't need that repeat exam. Those appendicitis cases, of course, are those that are positive. They're going to be transferred to Valley Children's or some other pediatric place, or an adult, a consult, a surgery, and admit. Just make sure to adequately manage with pain, emesis, make sure they have some maintenance IV fluids, and that their MPO status is MPO, and that they get started on some antibiotics. So the bottom line in the don't miss category is to keep your suspicion high for appendicitis. Don't anchor on a classic presentation, and consider differentials to avoid missing something important. Also, support your decision making process in your documentation with decision tools and by charting your thought process in general, as well as documenting shared decisions, follow up on term precautions. That's about it for this one. Hope you find it useful. Hope you find a useful nugget or two in there, and have a good shift.